Yeah, we are almost at the end of the morning, and a very important question to ask when we are endeavoring in this project is, has it any value? And because developing analytics, developing the infrastructure is a complex and difficult project. So our part in the AEGLE consortium was to evaluate the value of technology. Now, we do have some experience with that, and that is what we call early or health technology assessment. And the idea is that you use all kinds of methods to inform the stakeholders, and that is, for example, the funders, the hospital administration, authorities, about the potential value of new medical products. And in this case, we consider the development of big data analytics as a kind of a medical product, including the methods to quantify and manage uncertainty. And that has been written down by a colleague of ours from Twente, Maarten IJzerman. And what's about? It's about that you try to avoid flipping the coin, that you think, okay, this is going to work, or this, and that you actually have little ground to make an informed decision. And that's often the case still in medicine. It has often been the case that that developers are over-optimistic about the value of their ideas and technologies, and that at the end of the day, the value has been little. So, what did we do? We actually started out based on the experience, and actually I have to say that all the compliments should go to Lietske Bakker, who's you met yesterday, but is now on maternity leave. She did all the work in order, all the detailed work, nitty-gritty work, in order to arrive at some interesting results. And Ken and I have the privilege to present this to you. What's about? We developed a framework, and that is that we want to identify the clinical problems that big analytics could solve. And you see here what problems can you select, and you have a whole range of problems that you can select from in this project, a project. And it is up to the to a number of people to say what are the things that you want to select. Then what you do is it feasible? Can you do it? Can you develop the analytics that you want to develop? Can you develop the algorithm given the technology available to you? So it's an issue of the infrastructure and the IT that's available to you and the programming environment. What you then do is check whether you have sufficient data to address that problem. Because that's the whole idea of big data analytics, that you have a sizable amount of data that you can do to apply your algorithms and see whether you can solve the problem. And you see in this figure there is a kind of a feedback loop. Yes, you can go continue, and no, then you have to go back to the bench, to the drawing bench, and find a problem that would be worthwhile to select. If that check is possible, it is not said that your idea, your problem that you want to address in big data analytics will be of any value. So you need to do an early cost-effectiveness analysis in order to assess the benefits, in order to assess the economic benefits in terms of what about the money, what about the costs, and are there any alternate benefits that you would take into the equation in order to assess whether it is a worthwhile effort to develop the analytics. If that produces an answer no, you go back. If it produces an answer yes, you can continue the development. The whole idea is that you start this work at an early stage of development of your analytics in order to avoid wasted effort, that you have to decide that at the end of the day you have wasted all your resources in order to develop something that doesn't work. And that's a challenge. That will remain a challenge for big data analytics and for any IT development that you can consider as a kind of a medical intervention in the future. The whole notion of an cost-effectiveness analysis is, we have put that in a box in a number of stages that you, of course, and each of these stages requires a number of activities. For example, you may now decide to narrowing down the scope. That is that you narrow down what medical tests you could do. You would, there are a number of patients that, issues that you need to address in that early CA. For example, whom would you target? For example, if you address diabetes 2, then you might decide that it is worthwhile to address only a select group of patients, or a CLL in a similar situation. You might then go further and then decide what evidence is available, if we have different options in terms of one intervention, say the intervention with big data analytics and no intervention with big data analytics, and is there any evidence what either intervention would mean. And you have different methods in order to do so. In order to assess that the value, what you do is then develop a conceptual model. Usually it's something in the form of a decision tree with some Markov processes that in which you can enter the time element. How does it develop over time? And then you do your early cost effectiveness analysis, that you are adding the numbers, what are the alternatives or what are the costs of the alternatives. And you can then, according to the scheme, continue with recommendations for further development. That means that you either do it or decide, no, it's too much effort. We have done this approach, we have applied this approach to each of the 3 clinical domains that are part of this this AEGLE project. So we did it for intensive care, we did it for the CLL work that's much more research R&D oriented in itself, as you have heard yesterday, and we applied it also with this ongoing work to the management of diabetes 2 patients. What we will present now, and that's also very closely linked to Katerina's Vaporidis work that she presented just before us. So we applied our approach to the data provided by Katerina. This is the place where we got, I thought, always put in some sort of a cartoon into it. And I think the more detailed approach of how we did the analysis, I would like to give then the word to Ken in order to explain to you exactly what we did in the ICU case.
Jos? Yeah.
Yeah.
Okay. Thanks, Jos. So yeah, this was our opportunity to share with you some of the things we've been doing in the course of AEGLE. As Jos says, the central person who played an important role in AEGLE in general, but in particular in this work was Litske Bakker, who's on maternity leave. So that was, in fact, she was also involved in planning the symposium, helping to plan the symposium, all the logistics. And so we started planning it, and then it turned out that she announced, and by the way, I'm pregnant. So in a sense, it's not like she wanted to get out of this work. In fact, if anything, she would have really wanted to be here and share with you her ideas. And I think, as Joel says, we will do our best to share with you some of the insights that we gained. I think the starting point was something that we actually knew beforehand, but I think that it's good to point out a couple of things here. This whole methodology was something that I developed with a PhD student a few years ago, and we didn't start with this whole thing from scratch. No, on the contrary, we based this work on the steps that are found in the NICE guidelines for evaluating tests. So NICE in UK, the National Institute of Health and Clinical Excellence, has a well-documented list of steps in order to determine whether or not a particular test will be recommended for use. And because the Erasmus School of Health Policy and Management is, in fact, one of the evidence review groups from NICE, which is kind of odd because a Dutch institute working for the UK government is an unusual situation. Because we gained some insights into doing it using these methods before, we sort of reused it in a different way. Now, how are these steps normally used? Well, you have this medical test, and it could be like a new CT scanner, for example. And once this has been developed by Philips and Siemens or whatever, then the UK in NICE will assess whether or not a particular scanner or whether any particular test will be recommended for use. So the test has to be complete and ready for use in healthcare before this assessment begins. And this whole process that you see here takes a matter of months, 6 to 8 months. And basically, you start at the top here, and you basically have the scanner. The scanner, as you can imagine, can be used in many, many different ways. You can use it to scan patients who are healthy, children, older people, people who are very sick, people who are not very sick. And you have to identify how you're going to use this particular test, which particular patient population, and how these patients are currently treated, right? And then, I'm not going to go into all the details, but I just want to impress upon you the amount of work that goes into this kind of analyses. Now, this is after the test has been fully developed and is ready for use, as I say. So this is what we call a late cost-effectiveness analysis, right? And this will have, once the results are known, then the recommendation might be, let's use, this test should be recommended for use in the country. What we do now, though, is we've adapted it for use long before the test is actually ready for use. So this is an early cost-effectiveness analysis. While the test is being developed, maybe it's a good idea to see how well this test would perform if the test were complete and ready for use. And this requires a very good understanding about how the test could be used. Which kinds of patients would you use? How much could you improve health? And how much could you perhaps even reduce costs? So these kinds of steps are the steps that we could be using to gain insights into the potential value or the potential impact of the test on health outcomes and costs. So I'm going to, and this is basically what we do at the very end, this early cost-effectiveness analysis. And as I say, this takes a lot of time just to do it once. You want to do it well, and you don't want to do it quick and dirty necessarily, but you want to spend some time doing it. And we realized with big data analytics, you have a different kind of problem. Because you can do many, many different things with all the wonderful databases and the analytics that are available, you can do millions or hundreds of thousands of different tests and different things with that data. So that's why we thought, well, what we have to do is filter out or force developers to say, these are the problems that we think we can solve. And the starting point is basically identifying what we would call the clinically relevant problems. And that's by means of discussions with clinicians in particular, like Katarina, who will say, listen, I think based on what I see in practice, that these are the relevant problems I see on a daily basis or on a regular basis. And this is what I hear from colleagues. And you can imagine that you can make a list of the different kinds of problems that could be solved with the analytics techniques, including AEGLE, but this is also valid for all sorts of other initiatives. Once that list is made, and you can start with the first four, P1, P2, 3, P4, we've decided or realized that it's important to ask some really basic, really basic questions. Great idea, sounds good. Maybe it's an important point, lots of health loss occurs. Maybe we can find a solution for these patients. Two questions though, general questions. Do we have the technical ability to answer that problem or to try to see if we can find a solution for that using the techniques that we currently have available? And the second one is, do we have the data, right? And this requires dialogue because the person asking the question or coming up with the problem might have no idea about the technical suitability and might not yet have any insight into the data, right? And that's why these questions have to be asked before we would proceed with this time-consuming cost-effects analysis. So as you saw, though, so with Katarina, in her talk, she mentioned this idea of these ineffective efforts or clusters of ineffective efforts. And she, I think, communicated quite clearly to you that these are important things that need to be addressed, right? And in this particular case, the next step was that we needed to establish whether or not there was sufficient data in order to make it worth our time to proceed to the cost-effects analysis. And the answer was, yes, there is sufficient data in order to do this. And in addition, the analytics available could also be performed. So in a sense, my conclusion is it takes three to tango. You need a person coming up with clinically relevant problems, you need sufficient data, and you need to have the analytics to be able to find some patterns in the data. The question, and I admit to you the question is kind of long, but it's really, what is the potential impact on costs and health of adopting these AEGLE analytics to identify ICU patients with ineffective effort events and intervening compared to current care, right? So what's the basically what's the impact on health and costs if you treat these patients differently, right, than they are treated now? And the steps that or the method that we applied here was, of course, as you can see here, using patient-level data, which we didn't really analyze ourselves, but through Katarina and others, the data was able to be made available. And in addition, in combination with the literature on monitoring devices, costs, and existing cost-effectiveness models. And, of course, some insights through a clinician, which, of course, was Katarina. As Jules mentioned, one of the tools that we use, a widely used tool, is a decision model. And I'll just walk it to you quickly if you're not familiar with it. On the left-hand side, we have our patient population, which is mechanically ventilated ICU patients. Now, one option, this is a decision node, we can treat them using current care. And with current care, as Katarina said, these ineffective efforts are not picked up, right? They're not picked up, so therefore there's no intervention, and then this is the outcome for all the patients. So basically, this is the counterfactual. This is what would happen if we were to do nothing and treat them as we do now. With this choice up here, we can monitor them and use this AEGLE algorithm to see whether or not we can predict which patients will have these ineffective effort clusters. And this prediction, of course, is binary. It's going to be predicting, yes, this patient falls in the category of a patient with a cluster, or this patient does not. And here, you might be familiar with this concept of false positives, true positives, false negatives, and true negatives. Basically, you might be correct in predicting whether or not an ineffective effort occurs. But be that as it may, if the test is positive, then you're going to do something. If the test is negative, you're not going to do anything, right? And basically, the real question is, yeah, you treat these patients differently, but how much are you really going to save their lives or improve their health? And how much is it going to cost? And that's really what we want to get to. This covers, the decision model covers the actions, the test results, and the actions that we take. But really, we want to predict the future. And of course, that's why we have this Markov model tacked on at the end. And different things can happen depending on whether or not you've intervened. And this is shown in the schema below how we model that. Basically, patients stay on the ICU, they get moved to a hospital ward, and they get discharged if they're lucky. But obviously, anybody can die at any time. That's the big black hole in our lives. Let's say, so the real question is, how much will the prediction of ineffective efforts really change these people's lives, and how much will it cost us? Now here you can see a variety of different kinds of outcomes, short-term outcomes, long-term outcomes. And you can see with current care, we're talking about a fairly high price, right? 19,000 euros short-term. So this, ICU day might cost 1,000 to 2,000 per day. And if they're going to stay on the ward, in the ICU for 24 days, it really has a dramatic impact on costs. And the chance of mortality on the ICU is 30%, chance of hospitality mortality is 43%. Now with the smart alarm, we don't see a big difference. It's going to drop by 175 euros. But what we do see that there's a shorter length of stay, and in addition, there's a slight reduction in mortality on the IC and on the hospital mortality. So because of a reduction in cost and because of an improvement in or reduction in mortality, we consider this a situation of dominance, that is to say, a win-win situation. It's good for the patient, and it's good for the budget holders. The long-term effect is on the right, is what we see on the right-hand side. So here we see that life expectancy with current care would be something like little longer than 7 years, and with the smart alarm, it might be an increase of 0.3 life years or 4 months. If we adjust for the quality of this life expectancy, we see then that it's also improved to 0.22, so 2 healthy months, if you like. With these kinds of analyses, though, we want to be able to explore what the impact is of varying different kinds of elements in our analysis. And so here you can see the impact of varying different kinds of parameters on the incremental costs. How much this use of this alarm or the smart alarm with this algorithm might cost compared to the current care. It shouldn't surprise you, though, the cost of this AEGLE analytics has the most important impact on your results, right? But remember, this is not something you're going to be reporting to other people. This is typically for internal decision making. You want to basically see, what's the impact of varying these different things on the results of my product, the product that I'm still developing. And here you can see that if you increase the costs by a certain amount, you will see that the incremental costs will also change accordingly. I'll get back to that in a moment. In addition, you can do scenario analyses. These are very simple examples that I'm showing you here. But in the worst case, what you see here is a situation where you say, well, you know what? The ineffective efforts, that's just the way it is, and we can change what we do, but it will have no effect on mortality. So therefore, the worst case involves no impact on mortality and some increase in costs. So you spend money, but you get nothing out of it. So this is not really something you want to see. On the other hand, with the best case scenario, of course, that the situation is even better. You're saving more money, and you're reducing mortality even more. So this doesn't tell you too much, but basically it tells you you have to probably get more data to get a better understanding about the likely impact of your this alarm. We can do other kinds of scenario analyses, and this basically is clearly for internal decision making. How much can we charge for what we're doing, right? Because you have to cover your costs, but presumably a company also wants to make some kind of a profit. And in this particular case, what you can see is that if you vary the price, you can vary it quite a bit to 9,000, almost 9,000 euros just to break even. But sometimes to be competitive, you want to be able to say, okay, listen, to hospital directors or insurers, if I can save you money, and I can save you money within 1 year, and that would interest them much more than telling them, you know, I can't save you any money, but I can save you some lives. You want to be able to think about what kinds of values you can, or your value propositions at the end of the day. So the general results are as follows. You know, the methodology that we've used is not really that complex, but in fact that checklist or the flow chart that we've shown you basically enables you to sort of think beforehand about all the very, very simple thoughts about your value proposition. If you want to convince other people about what you're doing, you have to think about what you're doing and how you can translate what you're doing into health outcomes and costs. And what we show here has been applied to the scenarios in the other two domains that have been studied in the AEGLE project, type 2 diabetes and chronic lymphoid-like leukemia. These are simply to use criteria which are, I think, they serve as a wake-up call. In that sense, as I say, you can come up with great ideas, and people can think about the techniques, all the techniques they can do, but the techniques mean nothing if you can't translate them into some kind of health outcome or some kinds of costs. What is your value proposition if health insurers or governments want to see your impact on costs or your impact on health or whatever? You have to be able to show them what you mean, right? You cannot simply dazzle them with great graphics. You have to think about what you can actually say with your what you can say with your work. The criteria could be used to determine which scenarios were not yet ready for use, right? Sometimes you don't have the data now, but you might have the data in 6 months if you talk with other people. So you have to, as I say, it takes 3 to tango. In other cases, you have the data, you have the technique, but you're not sure about what kind of problems you need. Then you have to talk to clinicians. And so in the end, it's a collaboration, a situation of collaboration. And then by using the criteria, we could determine which scenarios were worth investigating in more detail. So I think then, in addition to exploring and visualizing the data analytics, it's generally accepted that it can also generate health and financial benefits, and therefore I think we have good reason to be very optimistic. But I think we have to be careful, since we all have busy lives, to think about what we can do to make sure that we spend our time wisely, spend our time efficiently. And I think this is a way, this is a checklist that helps to sort of think clearly before spending lots and lots of time on things that may not be useful after all. And so that my thought here is that the checklist is a valuable addition to early health technology and methodology that can support decision-making in industry. That's it. Thank you.
Both. Any questions from the audience? Yeah.
Yes, very nice presentation. These early cost-effectiveness analyses, they're rather different from classical cost-effectiveness analyses, where you try sort of as an independent review, you try to evaluate whether the costs and the effects actually are in balance and it's worthwhile implementing this sort of new invention. But this is really more like cost here, no, not really cost, but it looks more like a sort of internal business plan rather than a cost-effectiveness analysis. So if it then is more like an internal business plan, because cost is more like the price of the product, and if it's an in-house analysis, you can just you can play with the cost because it's related to the price. So I just wondered, so is it then not? I just wonder, is it not more? For instance, is it not too rigid then to work with cost effectiveness like life years gains, etc., etc.? Because I mean, it strongly depends the effects on the value proposition of the company, I mean, people like, for instance, they may like analytics, so we want it, and maybe we're not certain about the impact it has on mortality, but still we think it is better, and people and our clinicians, they like to work with these kind of tools, and so what is then the value proposition? So I thought, I mean, I think it's an interesting model, but it's also a bit rigid because it has been taken from classical cost-effectiveness analysis.
No, you're quite right. So I should have been clear about that part. There are two things, as you say. I mean, I think in pragmatic terms, you have to think about who your target audience is. Who do you have to convince later, right? And if you're busy doing these things, you could be, as you say, you could be thinking, I know that my client or the people we want to convince are really keen on visualizations. Then you can focus on visualizations, right? In other cases, if you're thinking about getting something reimbursed, right, then you have to think of that if they're going to be, if they want to see what the cost effectiveness is of your product, it could be a test or a drug or a medical device of any kind, then you'll have to do those analyses later, right? In the late analysis phase, and sometimes you have to, right? The classical one, right? So if you're expected if you're expected to provide the information, the cost effectiveness analyses later, right? Sometimes you have to do it yourself, or if you know that some government body like NICE will assess it using these methods, then you can do it yourself internally to see whether or not your product will be up to snuff, will meet the demands of the client at the end, right? And if you see that it falls short, that it's not going to make it, then, as you say, internally you can make some decisions. Should we continue with this product, or should we change the patient population? So you continue with the product, but you shift gears. You focus on a sicker population, or you focus on elderly population, or whatever. So that's basically this part here, changing gears a little bit. So you can, if you see that the analyses are poor, then you can go back to any of these different steps and change gears. But you're quite right. It starts with the criteria. If you know that your client or your target your target audience doesn't care about the cost effectiveness, you don't have to do it, right? But if you know if they do care about it, then you can do these analyses and to just peek into how your product will be assessed later.
True. Yeah. But the thing is, I'm fine with, and I agree with on that issue. But the only thing is that, I mean, there are things. So if you want to take a step, for instance, if you're a company, industry, and you want to take a step to go further with all the R&D and all that stuff. Yeah. I mean, all the costs of the R&D themselves. I mean, developmental costs can be tremendous in a company, so they should be taken into account as well. Yeah. Whereas they are not taken into account in a late cost-effective analysis because the product is already on the market.
Well, I think I've been involved in other studies with pharma where they developed the drug and they wanted to recoup their costs, and they pushed the reimbursement of the drug even though it wasn't necessarily so cost effective, right? And they've made the investment in their product and they try to change it at the end, right? And this is a sort of an opportunity for any developer, right, to see,
and see how the R&D costs can actually be gradually earned back.
It's an efficient,
once you implement the product.
It's an efficiency gain. So if they think, well, it's not worth proceeding any further, then in some cases they could switch gears. But sometimes you can't switch the techniques. You've invested in the techniques and the technology, then you can switch to another patient population maybe. And yeah.
Any other question?
With your early kind of trial of it, I mean, do you have any wins?
With wins in
well, like we'll try this one test and show that really has this. Is that what those numbers were? That CEA?
The cost effectiveness analyses.
Yeah, which were wins that were convincing?
Sorry. I mean, this kind of.
Well, with specific tests or specific technologies, did you try it out on specific? You start out with CEA.
Well, what we did was this is basically the sort of a pre-check before doing these kinds of analyses. But I think in this particular case, with this particular continuing with the effort to the idea of identifying patients with ineffective efforts, that seems to be at least a viable application.
Well, just to clarify, is CEA carcinoembryonic?
No, it's a cost-effectiveness analysis. Right. I'm sorry. Yeah. Yeah. Okay.
So the other question is, are these fractions or percents? Because if they're because they're different. I mean, if that's a percent, that's higher than the U.S. A lot.
Yeah, that's right. And so I was going to change this, but I'm sorry, I forgot. These are proportions, right? So this is proportion. The chance. These are percentage proportions of patients that die on the IC. So 30%. So it's pretty substantial.
That's a lot higher in the U.S., but I think it's because we're very easy at getting people into the ICUs, which might be a way to save a lot of money.
Yeah, yeah, that's right. But I think it relates to another point, though, and this is something that we did consider along the ways. You might think this is a great idea, but to what extent are these ideas in the algorithm predictive of what you could see in France or the U.S., right? If you develop in one hospital in Greece, for example, what are the next steps? But at least it's sort of say it's a wake-up call. If it can't even be considered cost-effective in that source population,
One other thing, the hospital one in the U.S., and we did some stuff. I think it runs between 8 and 15% mortality if you've been in an ICU. Hospitals run about 3 or 4% mortality, which is quite different. So there's probably different tactics, strategies. I know that you're more cost-effective. It'd be worth contrasting it with the U.S. to save some money in the U.S.
Yeah, that's right. I mean, in fact, in the past we've done work with diabetes, and it was the other way around. Anything that was very, very cost-effective in the U.S. was not necessarily cost-effective in the Netherlands, right? But that's also because it's driven by the cost per hospital day and the life expectancy of patients with diabetes and all sorts of things. So there's important issues that one analysis won't be won't fit all the different jurisdictions.